Welcome to the Surgical Educator's Advanced Online Surgery Masterclass. In this video, you will learn about when to convert a laparoscopic procedure into an open one. An evidence-based analysis. Allow the words in the podcast to permeate into your mind. Visualize the patient or patients discussed in your mind's eye, or run a mental movie of the patients to have an indelible impression. By doing so, you will experience an immersive and transformational learning experience. This will eventually result in achieving excellence in surgery. Thank you.
Thank you so much for having me. I mean, excellence in surgery is the goal, but we're going to see today that it doesn't always look the way people expect.
Yeah, exactly. And, normally when we talk about a medical diagnosis, there's this expectation of precision, right? Like engineering.
Oh, absolutely. The human mind just craves that binary certainty.
Right. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is, broken. But then you step into the world of surgery, specifically into an inflamed abdominal cavity.
And suddenly that pristine x-ray is totally useless.
Completely useless. You're looking at a landscape that is just incredibly murky. It's unpredictable.
It's the absolute definition of diagnostic muddy waters. I mean, a surgeon navigating an inflamed abdomen, they aren't looking at static architecture.
No, it's actively changing.
Exactly. The tissue is actively weeping fluid. It's fighting the intervention. The certainty is entirely gone. You're operating on tactile feedback and, well, real-time physiological data that shifts minute by minute.
Which is wild to think about. And that's exactly the landscape we are heading into for this deep dive today.
It's a high-stakes environment, for sure.
It really is. So if you're listening, lock in, because we are deconstructing Professor Dr. Selvaraj's masterclass presentation. Let's pull up slide 1 here. The title is The Surgeon's Dilemma, When to Convert, an evidence-based analysis of laparoscopic to open cholecystectomy conversion.
It's such a crucial topic.
It is. Our mission today is to take a decision that has historically been shrouded in a surgeon's subjective gut feeling and transform it into a precise, evidence-based science. And to do this, we're using gallbladder removal as our lens. Why this specific procedure?
Well, simply because it is one of the most frequently performed abdominal surgeries on the planet. I mean, millions of these are done globally every single year.
That was common.
Extremely common. And because of that volume, people, and honestly, sometimes even medical professionals, start to think of it as routine.
But I'm guessing routine is a dangerous word.
Arguably the most dangerous word you can utter in an operating room. The sheer volume of cholecystectomies means that, statistically, surgeons are going to encounter the extreme edges of biological probability.
So standard procedure can just go off the rails.
Oh, absolutely. It can start out feeling entirely standard, and then within 15 minutes, due to obscured anatomy or severe inflammation, it devolves into a highly lethal situation.
Wow. Okay, that really sets the stakes perfectly. Let's move to slide 2. Because we are looking at a fundamental paradigm shift here in how surgeons view their own actions.
Right, the traditional stigma.
Exactly. Historically, the surgical community has treated a conversion, meaning you start minimally invasively but run into trouble and have to pivot to a large open incision as like a personal defeat.
A huge blow to the ego. The psychology of the operating room is just intensely driven by performance metrics. Surgeons are highly skilled, very competitive professionals.
Sure, you have to be.
Yeah, and for decades, the culture subtly reinforced this idea that completing a surgery laparoscopically was a metric of personal competence. If you had to open the patient up, the implication was, well, it was that you simply weren't skilled enough.
But the data on slide 2 demands a total eradication of that mindset, doesn't it?
It does. The new paradigm states that a conversion is not a complication. A conversion is the mark of an actively safe surgeon.
And the core philosophy here is reducing human error to LARP, right?
Yeah.
As low as reasonably possible.
Precisely.
Right.
AARP.
I've really only heard that term in like aerospace engineering or nuclear power plants.
Well, it originated in those high reliability organizations because they deal with catastrophic risk. ALAR acknowledges a fundamental truth. Risk cannot be brought to absolute zero.
Especially not when cutting into human biology.
Right. That's a statistical fantasy. But what ALOC does is implement systems and rigid thresholds to push the risk down as low as is humanly possible.
So if a surgeon claims a 0% conversion rate,
they aren't demonstrating mastery. They are almost certainly taking terrifying, unnecessary risks with their patients' lives. The goal isn't zero conversions. It's zero preventable injuries.
and the scale of the data backing this up is just massive. Looking at the numbers here, a sample size of 108,472 patients, and exactly 5.9% of planned laparoscopic cholecystectomies require a conversion.
That number really requires a pause. Nearly 6 out of every 100 times a team walks into the OR for a routine gallbladder removal, the biological reality inside that patient forces the team to completely abandon their initial approach.
That's thousands of patients.
Thousands. Their anatomy simply did not permit a safe laparoscopic procedure.
It feels very much like an airline pilot executing a go-around. The plane is coming in, the winds shear unpredictably, and the pilot doesn't just cross their fingers and push the nose down.
Exactly. They push the throttle, pull up, and circle back.
Right. The passengers might get nervous, but the go-around isn't a crash. It's the exact maneuver designed to actively prevent a crash.
That is a perfect analogy. The surgeon who forces a bad dissection is the pilot trying to force a landing in a crosswind that exceeds the aircraft's limits. It's ego-driven, and it invites disaster.
But let me push back on those numbers for a second. Why is a 5.9% conversion rate acceptable? If a standard blood pressure medication completely failed 6% of the time and required hospitalization, we'd recall the drug.
That is a crucial distinction, and we really have to stop calling it a failure rate. That's the legacy mindset we are trying to destroy here.
Okay, so how should we view it?
It's a 5.9% rate of encountering underlying pathology that demands a different tool set. The medication analogy assumes the patient's underlying condition is uniform. In surgery, the pathology is wildly divergent.
Because everyone's insides look different under stress.
Exactly. You're dealing with chronic scarring, anatomical anomalies, tissue necrosis. Timely conversion prevents biliary injury and visceral perforation. The failure would be ignoring the pathology and refusing to convert.
I see. So the pathology dictates the approach, not the surgeon's pride. Which leads us to the next critical question. How do we know who falls into that 5.9% before they are even on the table?
Preoperative warning signs.
Right. Let's jump to slide 3, identifying the high-risk profile. The research lays out specific markers based on demographics, clinical history, and metabolic factors. Let's start with demographics: male, gender, and age over 65.
It's deeply important to understand the behavioral reasons behind these demographic markers. Why is a 66-year-old male statistically at a significantly higher risk than a 45-year-old female?
I'm assuming it's not just pure biology.
No, a massive part of it is delayed presentation. Societal norms often condition men to ignore abdominal pain. They push through the discomfort.
So by the time they show up to the ER,
By the time they actually present, that gallbladder hasn't just had one mild inflammatory event. It has undergone multiple severe cycles of acute inflammation, swelling, and cooling down.
and what does that cycle of swelling and cooling do to the physical organ?
It creates chronic scarring. It turns a soft, pliable organ into something thick and unyielding. And then, as we cross that 65-year threshold, tissues become more friable.
Let's define friable for the mental movie we are building.
Friable tissue is tissue that tears, crumbles, or bleeds easily upon manipulation. Imagine trying to sew a button onto a piece of wet tissue paper compared to a piece of denim.
Oh, wow. That is a terrifying visual.
It is. As we age, the connective tissue degrades. When a surgeon grasps a 70-year-old inflamed gallbladder with a grasper, the tissue might literally tear open, spilling infected bile and blood into the visual field.
Just a total mess. And then the slide points us to metabolic predictors: obesity, specifically a BMI over 30, and diabetes mellitus.
Obesity physically alters the geographic landscape of the abdomen. Like we said earlier, laparoscopic surgery relies on a pneumoperitoneum.
Inflating the abdomen with gas.
Yes, but in a patient with a high BMI, the heavy abdominal wall pushes down constantly against that gas pressure. The surgeon is physically fighting the weight of the patient's body wall just to maneuver their instruments.
Plus the visceral fat. Right?
Exactly. The fat surrounding the organs is thick and obscures the delicate structures. The liver itself is often heavier and fattier, making it incredibly difficult to lift out of the way.
And how does diabetes factor in? I usually think of blood sugar or neuropathy, not necessarily surgical anatomy.
Diabetes is fundamentally a disease of the microvasculature. Elevated glucose damages the tiny blood vessels that supply oxygen to tissues. So the gallbladder has impaired local circulation.
Meaning it can't heal or fight infection well.
Right. When inflammation hits, a diabetic patient's tissue is far more prone to ischemia, a lack of blood flow, and subsequent tissue death. And the surgical planes we rely on are often obliterated by disorganized scar tissue.
Speaking of scar tissue, the clinical history markers on slide 3 include previous upper abdominal surgery.
Previous surgery is one of the most daunting red flags a surgeon can see. The peritoneum, the lining of the abdominal cavity heals by forming adhesions, dense bands of fibrous scar tissue.
Like biological superglue.
Exactly like superglue. If they had a stomach ulcer repaired, the gallbladder might be densely fused to the duodenum or the liver bed. You cannot gently peel these organs apart laparoscopically.
Okay, next we have the biomarkers. A CRPC reactive protein greater than 76 and leukocytosis.
These are the systemic fire alarms. A normal CRP is usually under 10. When it spikes above 76, it tells the team the body is engaged in a massive inflammatory cascade.
And leukocytosis is the high white blood cell count.
Yes, the immune system has mobilized its army. Before the incision is even made, these numbers objectively confirm that the tissue inside is actively hostile.
So those are the systemic warning signs. But moving to slide 4, the master class takes us into objective imaging. We use ultrasound to look directly at the battleground.
Radiographic red flags.
Let's walk through these. First, gallbladder wall thickness greater than 4 to 5 millimeters.
To contextualize this, a healthy gallbladder wall is incredibly thin, usually around 2 millimeters. It's translucent and highly pliable, like a thin water balloon.
But with inflammation.
Massive edema. Fluid rushes in. A wall that measures 5 millimeters is profoundly swollen. It loses all pliability. It becomes stiff, heavy, and acts like a thick curtain obscuring the ductal anatomy beneath it.
The second flag on the slide is pericholocystic fluid, fluid pooling physically around the outside of the gallbladder.
A critical indicator of severity. The localized defense mechanisms within the wall have been overwhelmed, and it's weeping fluid into the abdomen. You are looking at potential localized gangrene.
And that destroys those natural tissue planes surgeons use to separate organs.
Completely obliterates them. The organs are just glued together in a wet, inflammatory mass.
And then the third radiographic flag, which has a statistic that genuinely shocked me, CVD dilatation, common bile duct dilatation, greater than 6 millimeters.
The math here is exponential.
The slide explicitly states that every 1 millimeter increase in dilation equals a 40% increased conversion risk. Wait, just a single millimeter increases the risk of open surgery by nearly half.
Yes, and it's terrifying if ignored. Let's map out the biliary plumbing. The liver produces bile, which travels down the main pipeline, the common bile duct, or CBD.
And the gallbladder is just a storage tank on the side.
Right, connecting via a tiny side road called the cystic duct. A normal CBD is about 4 to 6 millimeters. If it's dilated beyond 6, the main pipeline is under intense pressure.
Usually from a blocked stone.
Usually a stone, or the gallbladder is so massively inflamed it's physically crushing the CBV from the outside Maritzi syndrome.
And that 40% per millimeter jump.
It reflects the compounding complexity. A 7 millimeter duct drastically changes the approach. An 8 millimeter duct means you're navigating a pressurized system where one misplaced clip could sever the patient's primary bile flow.
It shifts the mindset from, I think I can manage this, to the objective math tells me this is highly dangerous.
Absolutely.
So we have the patient profile, the blood work, the ultrasound. We know exactly what we're dealing with. Now moving to slide 5, the masterclass introduces a variable the surgeon actually controls: time.
Ah, the 72-hour golden window.
Yes, the timing of the intervention. The data draws a hard line. If you intervene early, less than 72 hours from symptom onset, tissues are edematous, but planes can be separated safely. Why is early better?
It comes down to the timeline of the inflammatory cascade. In those first 72 hours, the primary response is edema tissue swelling from fluid, and while swelling sounds bad, in skilled hands, it's an asset.
How is swelling an asset?
The fluid acts as a natural hydraulic wedge. It subtly forces apart the layers of tissue. A surgeon can use blunt bisection to gently sweep along these fluid-filled planes. The tissue is wet, but it hasn't locked into place yet.
But the moment we cross that 72-hour threshold, we enter delayed intervention. And slide 5 says we see the onset of dense fibrosis and extreme hypervascularity. What happens at hour 73?
The body realizes simply flooding the area with fluid isn't working, so the immune system shifts from containment to isolation. Fibroblasts flood the area and lay down massive amounts of collagen.
Fibrosis.
Exactly. The soft fluid planes solidify into dense cement-like scar tissue. You can't gently sweep them apart anymore. You have to cut them, which is incredibly dangerous when visibility is low.
And the hypervascularity.
The tissue is desperate for oxygen to fight the infection, so it rapidly grows thousands of new, tiny blood vessels. But they are incredibly fragile.
Let me try a visceral comparison here. It's like dealing with water damage in a house. If a pipe bursts under your floorboards and you call a plumber within the first 72 hours, It's wet, it's a mess, but you can mop it up and fix the pipe.
That's the edematous phase, yes.
But if you wait a week, the water sits, black mold sets in, the floorboards warp and rot together. You can't just mop it up. You have to take a crowbar, rip the entire structural foundation apart, and rebuild it from scratch.
That is a perfect parallel, and ripping the floorboards apart with a crowbar is the exact equivalent of a forced open conversion. The laparoscopic instruments are too delicate to penetrate that fibrotic cement.
And if you force them,
Those fragile capillary beds tear, the camera lens is instantly blinded by bleeding, and when visibility drops to zero, you have lost control of the operation.
which highlights why objective measurement is so critical, human eyes just aren't enough to judge if tissue is edematous or fibrotic. So let's look at slide 6, which shows how surgeons mathematically quantify this risk pre-op.
The scoring systems, these are cognitive lifelines.
The two primary ones are the CLOC score and the RSCLO score. Let's break down CLOC first. A score greater than 6 is high risk. It evaluates age, male gender, thickened gallbladder wall, and the ASA grade. What exactly is an ASA grade?
ASA stands for the American Society of Anesthesiologists. It's a physical status classification system. Grade 1 is a completely healthy patient. Grade 2 might have mild disease, like controlled hypertension.
And grade 3.
Severe systemic disease that limits activity, poorly controlled diabetes, morbid obesity. So the CLOC score pulls in localized data and combines it with systemic vulnerability.
Then we have the RSCLO score. A score of 3 or greater is the high-risk threshold. It looks at age over 60, male gender, prior surgery, tenderness, and a thickened gallbladder.
And this score is remarkably predictive.
It really is. The masterclass highlights a stunning fact. An RSCLO score of 3 or greater yields a 100% sensitivity for predicting a conversion.
We must be very precise about what 100% sensitivity means in clinical statistics because people often misunderstand it.
Right? Does it mean every single patient with a score of 3 will definitely be opened up?
No. If it meant that, it would be 100% positive predictive value. Sensitivity acts like a perfect fine mesh net. It means that out of all the patients who did ultimately require an open conversion, 100% of them had an RSCLO score of 3 or higher.
So there's a 0% false negative rate.
Exactly. It catches every single dangerous case. If you score under a 3, your risk of a surprise conversion is statistically near 0.
If it's that highly predictive, why isn't it plastered on the wall of every preoperative holding area? What's stopping surgeons from using this universally?
Workflow integration and, again, surgical culture. It requires taking an extra moment in a compressed timeline to pull data and run the math. Some surgeons rely on heuristics, mental shortcuts.
But heuristics fail in edge cases.
Constantly. The push in modern surgical education is to mandate these scores as hard stops in the checklist.
Okay, so that's the pre-op baseline. Let's move to slide 7. What happens when the surgeon is actually inside the abdomen? The masterclass introduces real-time intraoperative scoring, the Nassar scale and the G10 score.
These are visual grading scales actively assigned during the procedure.
The Nassar scale identifies grade 3 or 4 as high risk, severe inflammation, a frozen Calitz triangle, and obscured anatomy. What does frozen mean here?
Calitz triangle is the critical junction of ducts and arteries. When it's frozen, fibrosis has completely encased those delicate structures in a rigid block of scar tissue. You functionally cannot separate them.
And the G10 score looks at complete burial of the gallbladder, access difficulty, or active sepsis. There's a hard surgical pearl here. Encountering a grade 4 Nassar demands immediate proactive conversion protocol.
Yes, grade 4 includes empyema and gangrene.
Empyema being pus in the gallbladder.
Right, a localized abscess. And gangrene means the swelling has physically choked off the blood supply. The tissue is dead, rotting, and incredibly fragile.
But practically speaking, a surgeon is in the middle of a high-stress operation. Alarms might be beeping. Are they really supposed to stop, look at the screen, and calculate a Nassar score in their head? Isn't that a distraction?
That is exactly the point. It is designed to be the distraction. It's a cognitive circuit breaker meant to combat the boiling frog syndrome.
Like the frog in water that doesn't notice the heat slowly turning up until it's boiled alive.
Precisely. In the OR, deterioration happens by degrees. You make a millimeter of progress, a capillary bleeds, you suction it, keep going. Visibility drops slightly, you keep going. The surgeon's threshold for what is acceptable slowly shifts. They acclimate to the danger.
Oh, wow. So the score forces them to snap out of it.
It forces them to step back from the microfocus of the instrument tip, look at the whole monitor, and objectively declare, I cannot identify a single landmark. This is a Nassar grade 4. The moment that label is applied, the objective algorithm takes over.
That's a brilliant psychological failsafe. Now let's look at slide 8, the anatomy of danger. What is the physiological threshold triggering this failsafe? It all revolves around the critical view of safety, the CVS.
The CVS revolutionized laparoscopic cholecystectomy. The entire first half of the surgery is solely to achieve this view. If you achieve it, cutting is safe. If not, you are gambling with the patient's life.
The data shows dense adhesions are present in 71% of conversions and obscured anatomy in 43%. Let's visualize the anatomy. We have the liver above, the gallbladder hanging beneath. What structures must the surgeon identify?
Visualize the hepatocystic triangle, top boundary, the liver bed, right boundary, the cystic duct, left boundary, the common hepatic duct. Running right through the middle is the cystic artery.
So the goal is to cut the cystic duct and artery to free the gallbladder.
Yes, but severe inflammation distorts the geometry. The cystic duct can become so swollen it physically merges with the common bile duct. If a surgeon guesses wrong, they might place a clip across the common bile duct and cut it in half.
And what happens if the common bile duct is severed?
It is a devastating, life-altering iatrogenic injury, meaning caused by the medical intervention. The patient leaks bile directly into their abdomen, causing peritonitis, sepsis, and organ failure.
And repairing it is a massive deal.
Right. Highly complex reconstructive surgery. The patient faces months of hospitalization and a permanently altered quality of life.
Which is why slide 8 has this hard, uncompromising rule. If the hepatocystic triangle cannot be safely cleared, stop and convert.
You must clear all fat and fibrous tissue away, peel the bottom third off the liver, and conclusively prove there are exactly 2 structures entering the gallbladder. If you can't clear that window, the CVS has failed.
And when it's failed, you convert. But as slide 9 reveals, not all conversions are equal. The mantra here is, anticipate, do not react.
Exactly.
2 paths.
Let's look at intentional conversion. This is 84% of cases, driven by lack of progress. Result: controlled environment, optimal patient safety, 0 iatrogenic damage.
This is the triumph of the algorithm. The surgeon pauses, steps back, and tells the anesthesiologist, we do not have safe anatomy. We are converting to open.
It's a calm transition.
Completely calm. The anesthesiologist adjusts meds. The scrub nurse pulls the laparotomy trays. It is a strategic pivot. The patient is never in imminent danger. All flawless strategic retreat. But then the forced conversion, the remaining 16%. Driven by massive uncontrolled hemorrhage, bile duct injury. Result: high stress, reactive damage control. Paint this picture for us.
This is the nightmare scenario. The surgeon ignored the 72-hour window, tried to muscle through a frozen Cowlitz triangle, and accidentally applied energy to a major artery.
Oh no.
Instantly, the pressurized abdomen fills with arterial blood. The camera lens is splashed red. They try to clean it, but the bleeding is so rapid, visibility drops to 0. Blood pressure is crashing, monitors blaring. They have to urgently slash a massive incision just to get hands on the bleeding vessel.
Pure chaos, a complete rat.
Yes. A forced conversion means the surgeon became reactive to a disaster of their own making. Intentional means they maintained absolute authority.
So to stay in that calm 84%, we need a trigger point, a time to pull the cord. Let's call up slide 10, the critical decision window. The magic number is the 35th minute.
Perhaps the most profound integration of data in the masterclass. It gives the subjective feeling of, this is too difficult, an objective timestamp.
The slide details that successful decisions to convert happen at exactly 35 minutes. And we have the rule of lack of progress. If there's no progress for 30 to 45 minutes, exercise an immediate low threshold for conversion. Why the 35th minute? Let's talk about the sunk cost fallacy.
The sunk cost fallacy is that irrational cognitive bias where we continue a failing endeavor because we've already invested time into it.
Amplified by adrenaline in the OR.
Exactly. The first 15 minutes are just setting up trocars and initial navigation. Then they reach the gallbladder. They struggle for 10 minutes, adjust, struggle for another 10. By minute 35, they've invested intense energy. The fallacy whispers, I can't give up now, just 5 more minutes.
I mentioned a traffic jam earlier. It's like sitting in gridlock for 30 minutes, thinking it'll clear up. By minute 45, you see an exit ramp for a detour, but you refuse to take it because you're so emotionally invested in the time you've already wasted.
Yes.
But in surgery, refusing the exit causes exponential harm. The slide warns, prolongation without progress exponentially increases complications.
The tissue gets more inflamed just from the instruments repeatedly slipping off it. Bleeding increases. Minute 35 is the fulcrum. It's long enough to have given a fair attempt, but short enough that the surgeon's brain hasn't descended into pure tunnel vision.
They still have the psychological flexibility to take the off-ramp.
Exactly.
This connects directly to slide 11, the human factors of surgery. Surgeons are humans subject to limits. Performance peaks between 45 to 90 minutes. After 90 minutes, we enter the danger zone, severe cognitive and motor fatigue. And this quote, bravery replaces judgment.
Bravery replaces judgment. That should be etched in every OR. When a surgeon is in their 45 to 90-minute flow state, they use judgment. They assess risk deliberately.
But at minute 120,
Their forearms are burning, neck is cramped, glycogen is depleting. Decision fatigue completely overwhelms the prefrontal cortex. Out of sheer frustration, they try to brute force the anatomy. They become brave, which results in a severed common bile duct.
the slide emphasizes occupational humility. But wait, I have a question. If peak performance is up to 90 minutes, why mandate the decision to give up at minute 35? Shouldn't they use that peak window to keep trying?
That is an incredibly astute observation, but we have to reframe what the conversion is. Converting to open surgery is not the end of the operation. It's actually one of the most physically demanding, complex reconstructions a general surgeon will perform.
Oh wow, the 35th minute decision is about allocating energy for the real fight.
Precisely. The decision must happen at minute 35 so that the actual execution of the complex open surgery occurs squarely within the surgeon's 45 to 90-minute peak performance window.
That makes so much sense. If they struggled for 90 minutes and then converted, they'd be deeply fatigued.
Exactly. Operating in the danger zone. Occupational humility means having the wisdom to conserve your peak energy for the safe path.
Profound. But what if they recognize the danger at minute 35, but an immediate open conversion isn't the only option? Let's look at slide 12, bailout strategies. We have two primary approaches for the difficult gallbladder.
Yes, advanced techniques if standard dissection fails.
First is the laparoscopic subtotal cholecystectomy. Ideal for severe inflammation or Morizzi syndrome. You remove the anterior wall, evacuate stones, and close the stump, bypassing callets entirely. Wait, so you just leave a piece of it in there?
You do. And this requires a massive shift in mindset, which traditionally dictates leaving diseased tissue as a failure. But if the hepatocystic triangle is frozen solid, dissecting the base is suicidal.
So what's the actual mechanical process?
The surgeon opens the top, the dome of the gallbladder, suctions out infected bile and stones, then trims away the front wall.
But won't the remaining back wall get infected again?
That's the crucial second step. The surgeon must meticulously burn away or ablate the entire mucosal lining of that remaining back wall using electric cautery. Then securely stitch the stump closed. The patient retains a small inert patch, but the danger is gone, and the common bile duct was never touched.
An elegant compromise. The second strategy is the fundus first, or top-down approach. Dissecting downward from the fundus. How does flipping the map help?
Standard technique starts at the bottom triangle. If that's a dangerous mess, you reverse it. The fundus is the dome, furthest from the ducts. You peel it downward off the liver. It acts like a flag, gradually exposing the structures from behind.
But the slide concludes with a massive ultimatum. If these techniques fail to establish immediate safety, proceed to an open conversion.
These aren't excuses for heroics. They are alternate routes. But if those routes are also blocked, the algorithm demands you take the open conversion exit ramp. It's the ultimate safety net.
Okay, moving to the final phases here. Slide 13, technical discipline in the OR, the micromechanics of surgical execution. First, camera discipline. Keep the target of dissection centered. If you cannot see, stop. Sounds obvious. Why is it a pearl?
Because of the limits of 2D screens, you lose 3D depth perception. In the heat of dissection, a surgeon's eyes track the silver tip of their tool. If the camera isn't centered, the tip might be pushing into a dark corner.
So they can see the tool, but not what's behind it.
Exactly. Blind dissection is the primary cause of forced conversions. If the target isn't dead center in a brilliantly lit field, freeze all motor movement until the camera is corrected.
Next pearl, energy devices. Cope vessels gently. Do not stretch tissue while applying energy. What is coaptation?
Using devices like ultrasonic shears to apply intense heat and pressure, physically melting the collagen in vessel walls together to seal them.
Why is stretching dangerous?
Thermal spread. If you pull tissue tight like a rubber band, you create tension. Apply heat, and that thermal energy races down the tension fibers like electricity down a wire. You might cook the common bile duct resting 3 millimeters away.
Wow, just from pulling it too tight.
Exactly. The duct wall dies, falls apart a week later, massive bile leak. Gentle coaptation keeps energy localized.
The third discipline is culturally jarring. Systematic review. Record your surgeries. Repeating a complication means a flaw in technique, not bad luck. That's intense accountability.
It shatters the ego defense. When a complication occurs, surgeons naturally blame the patient's anatomy. Inflammation was too severe. But radical accountability means sitting in a dark room watching your own failure on video.
Tracking the exact moment it went wrong.
Yes. If you consistently tear the cystic artery in high BMI patients, that's not bad luck. It's a flaw in biomechanical technique. Master surgeons ruthlessly audit their video.
And the final pearl brings the math to reality. Team dynamics. Always operate in duo with a senior surgeon for highly predictive RSCLO equals 3 cases.
You don't walk into that OR alone. You check your ego, call your senior partner, and put 4 expert hands on the problem. It doubles cognitive bandwidth and acts as an external check against the sunk cost fallacy.
Incredible. All right, bring it all into pristine focus on slide 14, the conversion algorithm. A unified 5-step checklist. Let's walk through it.
Step 1. Stratify risk preoperatively. Calculate CLOC or RSCLO.
Step 2. Intervene strictly within the 72-hour golden window. Catch it in the edematous phase before fibrosis sets in.
Step 3. Assess intraoperatively using Nassar or G10 scales. Break the boiling frog syndrome.
Step 4. Enforce the absolute 30 to 45-minute rule, the 35-minute fulcrum. Make the decision while you still have cognitive sharpness.
And step 5. Convert intentionally, never reactively. Be the pilot executing a safe go-around.
It's a phenomenal architecture for safety, replacing gut feeling with an algorithm of uncompromising safety.
Absolutely.
Which brings us to our final stop, slide 15. Masterclass conclusion. A guiding principle from Professor Dr. Selvaraj. A timely conversion is the ultimate demonstration of surgical wisdom.
That perfectly crystallizes the paradigm shift. Evolution from ego-driven surgery to patient-centric care. Knowing your limits, trusting data, and prioritizing the human being on the table.
Prioritize patient safety above surgical ego. A powerful mandate. But as we wrap up, I want to leave you, the listener, with a provocative thought. We've talked entirely about how the surgeon manages this decision, but think about the communication before the surgery, in the clinic.
The patient's perspective.
Exactly. If you're a surgeon, how do you explain to a patient beforehand that waking up with an 8-inch open incision instead of 3 tiny Band-Aids isn't a medical failure, but a deliberate act of protection? Because patients view open surgery as a complication too.
They absolutely do.
How do we shift the patient's paradigm? If a patient goes to sleep, understanding that a conversion means their surgeon was disciplined enough to protect them from a catastrophic injury, maybe the stigma vanishes from both sides of the scalpel.
The informed consent conversation must evolve alongside the algorithm. Transparency empowers the patient and relieves the surgeon of the pressure to perform miracles in the dark.
We started out talking about X-rays, craving binary black and white certainty, safe or unsafe.
But the inflamed abdomen refuses to give you black and white. It gives you murky waters.
And you don't navigate those muddy waters by just pushing harder. You navigate them with data. You use the red flags, the 72-hour window, the 35-minute circuit breaker as your compass, and when it's time to change course, you execute that intentional go-around. That is how you turn a dangerous dilemma into a demonstration of absolute surgical wisdom. Thank you so much for joining us on this deep dive. Keep running those mental movies, keep pushing for excellence, and we will catch you on the next one.